So we're going to discuss a few things. First, I'll show you the normal, that is a normal salivary gland and how it looks and what's the histology of it. And then we'll discuss the pathology part, that is about a sialolith. What is a sialolith? What are the radiographic appearance and what's the treatment? And we'll study about what's a mucocele, and there's something called as ranula, which is like a variant of a mucocele. So we're going to discuss these three salivary gland pathologies today. This was a poem which was written by William Shakespeare, which I want to quote before we start the lecture today. So saliva is not one of the popular body fluids. Why? Because it doesn't have the drama of the blood. Sweat, which is related to the sincerity, that is lacking in saliva, and the emotional appeal of tears. So it's one of the body secretions which is not, it's like non-existent basically. So that's what he tries to say, but it is very, very important and very much existing for us as dentists. The salivary glands, which are the parotid gland, the sublingual gland, I'm talking about the major salivary glands, and then there is submandibular gland that is just below the mandible. So these three are considered as the major salivary gland. Of course, there is the submental, there is minor salivary glands which are present all over your mouth in various locations. So there are several salivary glands basically, and that's one of the ways to differentiate from the skin. Skin does not have any salivary glands. Instead, it has sweat glands, sebaceous glands, but the glands which are unique to the oral cavity is the salivary gland. It doesn't have the sweat gland and hair follicle and other adnexal structures. So the salivary gland diseases are classified as obstructive disorder, functional disorder, non-neoplastic and neoplastic. So today we are going to discuss these two, that is the obstructive and functional. So the next week we are going to discuss the neoplastic disorders, under which you will study benign salivary gland tumors and then the malignant salivary gland tumors. So this is the obstructive salivary gland disorder. It is called as a Sialolith. Sialolithiasis means salivary gland stones. Sialo is a term which refers to the saliva or the salivary gland. So lith is referring to the stone here. Okay, so whenever there is a stone within the salivary gland for whatever reason, then it is called as a sialolith, and it is the most frequent cause of any kind of swelling which is related to the salivary gland. Suppose a patient comes to you and he says that there is a swelling in the floor of the mouth or wherever he's showing, and if there is salivary gland in that vicinity, your first differential diagnosis should be a sialolith, and then you will ask him other symptoms. So all the major salivary gland as well as the minor salivary glands are affected. So which means your parotid, submandibular, sublingual, along with all other minor salivary glands. The age group which is affected is quite broad. From 30 to 60 years, anybody can be affected, and males are most commonly affected compared to the women. And there is a cyclical gland swelling. So when I say cyclical gland swelling, which is associated with the males, so if you remember that psychological experiment where the dog drools every time it is the time for the food, every day at the same hour, if he's been given his meals, then around the same time he drools, because his saliva knows that his body knows that he's going to get the food soon. So even our body, when you see something tasty, there is salivary secretion. Okay, when you like something which you're eating, or when you think of something like a pizza or a pasta or a burger or whatever. So this swelling is associated with the males when the saliva has to be secreted. One of the functions of saliva is to help with the mastication. It is not only to moisten the food which you're eating. It is also to create that chyme and the bolus within your mouth, which later goes into the further areas of your gastrointestinal tract. And it also has certain enzymes which break down. It's a coarse breakdown, but still there is some amount of breakdown of your foodstuff within the oral cavity before it proceeds to other enzymes present in the gastric and the intestine. Yeah, so for this reason, every time you're eating food, there is secretion of the saliva. So this results in swelling as well as pain. That's why it's called cyclical swelling. It's not present all the time. It is present whenever you are eating your food. So these stones, as you can see here, there are two of them. Okay, they're also called as calculi. I think you know plaque and calculus, which are related to the tooth as well. So any hard tissue deposit is called as a calculi, actually, if it's a mineralized hard tissue deposit. Okay, so these are also called as calculi, and it is mostly composed of the calcium, but it can also have magnesium, potassium, and ammonium. So these are the minerals which are present within these stones. And diagnosis is mainly done by the characteristic history and the physical examination. The patient is going to say that whenever there is a meal time, then whenever he's having food, he experiences this sharp pain and swelling in his oral cavity. That will be the chief complaint of the patient. And another thing which you can do in the chair side is by using lime. So lime drops will cause immediate swelling and the pain with the associated stone in that area. So that's another way you can do the characteristic examination within the chair side. And of course palpation, when you use your two fingers or when you use your digits for feeling the things, it's called as palpation, and you can see that there is something hard underneath the soft tissue. Okay, so diagnosis can be further confirmed by investigations, like you take an x-ray and then you will see that there is calculi which is present, and 80% of the salivary gland stones are visible on the x-ray. There's something called a silogram. So silogram is a type of radiography. What you do is you inject a dye into the salivary gland area, and then you take a radiograph. Okay, so that's called as a silogram. So that will show where the obstruction is, or where the stone is present, or where some kind of cut has happened within the salivary gland or the duct or whatsoever. So all that is shown by a silogram. So that's one of the other way of investigating the presence of the salivary gland calculi. And also you could do ultrasound, as you can see here. So this is an ultrasound which could also show the presence or absence of a calculi. So these are various diagnostic ways of detecting whether there is a sialolith or not. You use a lime like lemon. So you can use some drops of lemon, which will have the same effect as you know how when you want to eat something there is salivary secretion. So the same thing will happen when you add a few drops of lemon. It will cause the swelling and pain for the patient. So they use food. You cannot obviously order a pizza for the patient in your clinic. So instead you use drops of lime. Okay. So the treatment is surgical removal. You have to remove it, otherwise the patient will suffer. It's not very easy to tolerate that kind of pain, and it's quite sharp and shooting pain. So you remove the stone, and it's usually more than one stone. Okay, it's more than one number of stones which are present. So by your investigations, that silogram or your radiography, you can see how many stones are present and where, and you will make sure that it is removed. I'll show a video of that just to make you understand. And it has to be done under antibiotic coverage, if you know what that is. So suppose you're doing some like surgical procedure which involves like incision, suture, and maybe removal of something. So you want to do it by giving antibiotic like 2 or 3 days before, so that the patient doesn't have any secondary infection after you finish the procedure. Okay, so normal, even like your extractions like impaction and all this, you do it under antibiotic coverage so that there is no secondary infection later on. So you do the same for the Sialolith as well. So you can see it's like so hard, looks even like a tooth. This one, very notorious looking Sialolith we have, and quite big as well. So that was a obstructive salivary gland disorder. Okay. We now are going to discuss the functional disorders of salivary gland, under which we are going to discuss what is called as mucocele. Under mucocele, again, there are two types which we will discuss, and there is something called as ranula, which we must know. So mucocele is quite a common salivary gland disorder again, and it is usually secondary to trauma. A lot of us might even have mucocele without even realizing. If you have any lip biting, this habit, or cheek biting habit, then that trauma, if there are any minor salivary glands which are present in the area, can result in a mucocele actually. That is secondary to trauma, like I said, and 70% occurs in the lower lip because it's the most common area where trauma can occur. And ranula, like I said, is a variant of the mucocele, and it is usually seen in association only with the sublingual salivary gland, very rarely with the submandibular, but most often it is seen with the sublingual. Okay, that is just below your tongue and in the floor of the mouth. If you open your mouth, it's very interesting. I know that you've not yet started treating the patient, so you could do it in your own mouth. So if you go home in front of the mirror and if you just lift your tongue, there are like two apertures through which, like, saliva just spurts out like a fountain. So that's your sublingual salivary gland duct opening, basically. So that's where you will see the mucocele, and it's quite big in size compared to the mucocele, which are smaller in size, and that is called as the ranula. So we'll study each one of them more in detail. So like I said, for mucocele, trauma is the main cause, and any salivary gland and their ducts can be involved in this salivary gland lesion. And the reason is obstruction of the duct. As you can see here, there is a mucus plug which is obstructing the duct of the salivary gland. It could be a minor salivary gland or a major salivary gland, but as long as there is an obstruction, that can result in the accumulation of the mucus in that area and then results in a cystic swelling. I've already taught you cysts, right? So you know that cyst is like an empty cavity which is filled with the fluid and something which is lined by an epithelial lining. Okay, so this mucocele is nothing but like a cystic lesion, basically, but related to salivary gland, not odontogenic. Okay, so because of an obstruction, there could be a cyst formation. That is one of the reasons. And this obstruction could even be from the calculi, the Sialolith, which we discussed. Okay, so the Sialolith might have formed somewhere here, and it might have obstructed the salivary gland or the duct. So that will result in whatever saliva is coming from the excretory ducts are all getting accumulated here. Secretory ducts, sorry, not excretory. Secretory ducts are all getting accumulated here. They have no way of getting excreted outside, and hence they accumulate and form a cyst. So that's the other cause. One is the mucus plug. The second is the calculus or the Sialolith. Or even from the contraction of scar tissue. Sometimes what happens, there is a trauma for whatever reason, and there is a scar tissue around that trauma area. So this scar tissue will undergo contraction, and this is followed by a trauma, and that can also result in the formation of mucocele. So there are two types of mucocele here. One is called as the extravasation. The other is called as retention. Okay. So when we are talking about extravasation and retention, we are referring to the mucus. Okay. What is happening to the mucus? There are two types, serous and mucous salivary glands. So here we are talking about the mucous salivary glands. And whenever the mucus, which is secreted from the salivary gland acini, what happens to that? Is it extravasated or is it retained? So based on that, it is classified as extravasation mucocele and a retention mucocele. So among these two, first I'll tell you how each one is formed, and then you will understand it better. So in a mucus extravasation phenomena, there is a trauma. Okay. So this is the duct, okay, which has become cut, or there is a severance of the duct. So this continuation has been hindered. Okay. So because of that, the acini which are producing the mucus, instead of going into the oral cavity, okay, via this excretory duct, it is disturbed and it is just draining out in the surrounding, okay, like a pool of mucus. So because of this, there is a reaction, and there is like a wall of granulation tissue which is formed around this mucus pool that creates a cystic lesion. That is the extravasation mucocele. So I'll repeat one more time. There is trauma, excretory duct is cut, the mucus which is produced by the acini gets pooled in the surrounding tissue instead of going into the oral cavity. And because of that, there is a reactionary granulation tissue around it. Okay, and that's why it doesn't have an epithelial lining around it, so it's sometimes called as a pseudocyst, okay, or a false cyst. Whereas a retention mucocele is called as a true cyst or a true retention cyst because there is some kind of obstruction in the pathway of the salivary gland secretion. So here there is either a salivary gland calculi or a stone or even the mucus plug which has become hardened. So because of that, again, the secretion from the ducts are not able to reach the oral cavity. They're getting pooled, and you can see that the excretory duct is becoming bigger like that. So it becomes a fluid-filled cavity with an epithelial lining, and that's why it is called as a true cyst. All right, so this is another picture again showing the same extravasation cyst, that there is a severance of the duct, the excretory duct. So the mucus which is produced is all extravasated to the surrounding. That initiates a granulation tissue reaction and forms a pseudocyst. So this extravasation type is far more common than the retention type, okay? The retention type, as you know, needs some kind of obstruction, mucus plug or Sialolith or something. But trauma is much more common than these situations, either by yourself, self-inflicted, or from external reasons. So because of that, this is much more common. That is your extravasation type. The mucus retention cyst is also called as mucus duct cyst or a sialocyst. It is a synonym. So you can see it's a very clear, translucent swelling in relation to the minor salivary gland of the lip in this area. Here you can see it in the floor of the mouth associated with the sublingual salivary gland. Yeah, so any salivary gland is affected, whether it's minor or major. And it is quite superficial and asymptomatic. You will not have any pain or any kind of irritation, nothing. You will not have any symptoms at all. The growth rate might be variable. Like it can be either rapid or it can be slow depending on the patient. And there is a gustatory swelling and pain again, like I said, associated with the meals. And upper lip, cheek, and floor of the mouth are the common areas. As you can see here, there is lip and floor of the mouth already shown. Even your cheek, that's the buccal mucosa, is another site which can be affected. And you can see that the overlying mucosa is intact. There is no break, there is no ulceration, and it is of normal color. It is not different from the color of the surrounding structure. That means there is no inflammation. So this is how you will differentiate from other inflammatory reactions or lesions and from the ulcers. Okay, there are a lot of mucocutaneous lesions which start like this but then later becomes ulcerated. And of course the region, like the site itself, can be quite diagnostic based on where it is situated. Okay, so that's the clinical picture of the mucus retention cyst. Let's see what is the histopathology. So it can either occur as a single cystic cavity, as you see here, but there are times when it can occur as multiple cystic cavity as well, because probably the mucus is extravasated in like increments, and every time it has done that, there is like granulation tissue surrounding that has reacted in a proliferative manner. So that's why there are like multiple cystic spaces which are seen in those patients. And these are not lined by proper epithelium. It is surrounded by normal compressed ductal epithelial cells. Okay, whatever cells are present in the salivary gland duct, the same cells will be compressed and will be surrounding these cystic cavity. And it can be either stratified squamous epithelium, that is, it might have layers, or it might just look like it is having layers. In that case, it's called as pseudostratified. Okay, and the cystic lumen, of course, will have mucin. And because this is the retention cyst, the causative factor, that is the calcified sialolith, can also be seen within the around the cavity, which is the causative reason behind the cyst. Okay, and the connective tissue around the lesion is minimally inflamed. It's not like there is a lot of inflammatory reaction. Even here, if you see, there is not much inflammation which is seen. So this is the extravasation type, that is the severed duct. The histopathology for the extravasation type. This is the severed duct, as you can see here. And there is a pool of mucus, and there's a granulation tissue wall, and surrounding that is the epithelium. So this is the histopathology of a extravasation cyst. Another mucocele, this is quite bigger in size. There is a cystic space which is filled with the mucinous exudate, and it is lined by the granulation tissue. And these are all, see here, another reason, another way you can detect whether it is salivary gland lesion or just some normal cystic lesion is the presence of the salivary glands. All these are salivary glands around it. Okay, you will see surrounding areas with plenty salivary glands. And in a higher magnification, there will be a large number of foamy macrophages which can be seen. So here you will see a lot of macrophages within the connective tissue wall or the cystic wall. And sometimes you can even see like the necrosed salivary glands here. They don't really look necrosed. In the severed area, you can see the necrosed salivary gland. So the differential diagnosis, number one is the salivary gland tumors, with mostly benign tumors, not the malignant ones, but the benign ones might have similar pictures. So you need to differentiate from that. But of course, the histopathology is quite different. This will show proper presence of mucin, and some benign connective tissue neoplasms, so fibroma and lipoma. So these two connective tissue neoplasms, the benign ones, look very similar clinically to your mucocele. Okay. So what is the treatment? You have to do an excisional biopsy. I hope by now you know what is excisional and incisional. Excisional is usually done when the lesion is small, okay? But incisional is done when the tumor is very big or the lesion is very big, and you normally take out a part of the lesion and a part of the surrounding tissue. That's called incisional biopsy. But this is an excisional biopsy, and that is the choice of treatment as well, because when you take the tissue for biopsy, that is like removing the lesion, and along with the cyst, you should also remove a part of the duct which is affected as well. And marsupialization is another treatment. This I've explained to you in the odontogenic cyst as well. So if it is a little bit bigger, then you kind of make an opening by placing a silk suture on the roof so that it shrinks in size, and then you can go with the excision, the total excision of the mucocele. And a very popular treatment these days is by using the laser. So you can use a laser. There is a minimal bleeding, and the healing is faster in such cases whenever laser is used. So that is becoming a popular choice of treatment. And the next salivary gland neoplasm is ranula, which is similar to the mucocele, but it is bigger in size and it is situated in the floor of the mouth. Okay. So this specifically occurs in association with the sublingual salivary gland, and like I said, very rarely the submandibular as well, but the most common is sublingual. Okay. And it is bluish in color. Here it's kind of reddish, but yeah, reddish bluish in color. It is dome shaped. The shape of the lesion is dome shaped, and floor of the mouth, like I said, is the site. It is bigger than the mucocele, as you can see here. Mucoceles are quite smaller in size, whereas ranula is quite huge in size, and it is usually present, if this is the midline, it is present lateral to the midline. Okay, it is a lateral lesion. A lot of lesions are also classified based on whether it is present in the midline or lateral to the midline. So hence this is a lesion present lateral to the midline. It is fluctuant because it is a cystic swelling, and it is soft because it has fluid within it. Yeah. So, and it is usually unilateral. You don't see any bilateral occurrence of ranula. And it is painless, like your mucocele. There is no symptoms of pain or something. The reason it is called as ranula is because it resembles the underbelly of a frog, which is of the species Rana. Okay, that's why it's called as a ranula. So the belly of the frog looks similar to how the ranula looks within your floor of the mouth. And if at all it is situated in deeper layers, not superficial, suppose if it is present in the deeper, like mucosal layer or something of the floor of the mouth, then it loses its bluish translucent color, and it might appear as normal color of the mucosa. And if they're very, very big, then it has the ability to displace the tongue, both superiorly as well as medially. The patient cannot really keep the tongue in its position. It will be displaced superiorly and medially. Okay, that's another indication of ranula. And consistency is that of the mucus, and the lesion does not blanch on compression. The reason we are telling about blanching is if it is any tumor related to the blood vessel, then it blanches on compression. This I've told you in hemangioma, right? So if it is an hemangioma, it blanches under pressure, but this does not blanch under pressure. And it is one of the differential diagnoses because even this appears bluish and it is dome shaped, it is soft. So very similar to the clinical picture of hemangioma. So you must differentiate by the blanching test. So the glands affected are sublingual and submandibular very rarely. So if the mass is very big, your functions of speech, mastication, breathing, and swallowing, all of these are affected because when it is big, I told you, it displaces the tongue. So because of that, all these functions which are related to the tongue are affected. And why respiration? Because the tongue, when it is superiorly displaced, it's going to block your oropharyngeal airway, and that's the reason you cannot breathe properly. Okay, and even like mastication, you cannot really chew your food properly and then later swallow it. And when oral ranulas are large, like really large, then the tongue can put pressure upon the lesion as well. So this can interfere with the submandibular salivary gland flow, and as a result, it can result in obstructive salivary gland signs and symptoms like pain or discomfort while eating, feeling of swelling or fullness in the site, and increased swelling of the submandibular gland. All these symptoms will be seen as a sequelae to the large ranula, which is pressing on the gland. The treatment, like I said, because it is very large cystic cavity, you do marsupialization. That is the treatment of the choice, and the associated major salivary gland have to be removed along with the ranula. So the laser ablation, that is the laser treatment. Ablation is you're using a laser or some form of heat to treat the area. Okay, and cryosurgery is by the cold. Cryo is freezing, so you use either an instrument which is very cold, or you have some form of delivering very freezing kind of the tissue. You freeze the tissue and then you take it out. That's called as cryosurgery, which also is quite popular, but depending on where the lesion is present. So these two are the treatment of choice, but before you do anything, you have to do marsupialization. That is, you open a window, keep it open, and so that all the cystic fluid is drained out and the cyst kind of shrinks in size, and then you remove it by using laser or cryosurgery. And apart from the lesion itself, you have to remove the major salivary gland as well. So there is something called a cervical ranula. It is not seen within the oral cavity, but as you can see, it is seen in the cervical area, and that's why it's called a cervical ranula. And it is asymptomatic, and there will be a prior history of Sialolith, that is your salivary gland calculi, and maybe the submandibular ducts were transpositioned for management of severe drooling. Some patients, if you've seen, especially the ones who are mentally retarded, there is constant drooling which is happening. So for them, you transposition the submandibular duct so that that severe drooling is controlled. Even in some old people, this could happen. So there will be a history of these two things. That is a procedure done for the severe drooling, or Sialolith which has been removed. So in large oral and cervical ranula, there is dysphagia and respiratory distress, because there is oral ranula as well as there is something in the cervical area. So the dysphagia is difficulty in swallowing, okay, and respiratory distress. Both these can be a symptom. The patient might have a history of preceding oral swelling or concurrent oral mass. Concurrent meaning at the same time. So he can present oral lesion at the same time as the cervical ranula. So whenever you're seeing oral ranula, big one, you also check for the cervical ranula, the presence of it. The elimination of cervical ranula depends on the complete surgical excision of the oral portion first with the sublingual salivary gland, and if it is associated with submandibular, then you remove the submandibular as well. And the most important factor in surgical management of the cervical ranula is the removal of the responsible salivary gland. Okay, so that is the most important factor in treating it. Otherwise, it's going to come back, basically. So these are all the differential diagnoses for your mucocele and the ranula. Gingival cyst, you can differentiate it because it will have a clear fluid. Solitary bone cyst, it will have blood in it. Staphnous bone cyst will be empty with just air. Dermoid cyst will have sebaceous material. Fissural cyst will have mucoid fluid. Vascular cyst wall will have fresh blood. Cavernous hemangioma again will have blood. Arteriovenous malformation will have blood. So that's how you differentiate by, especially if you're doing a fine needle aspiration of any of these cystic lesions, you can differentiate it from the mucocele or the ranula.